Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Scoliosis and Spinal Deformity. What is it and what can be done about it? Presented by Dr. Rajiv Saigal, Medical Director of Spinal Deformity and Spinal Tumors with Washington Hospital Healthcare System, and Neurosurgeon with UCSF and Washington Township Medical Foundation. Dr. Saigal is an Associate Professor and Neurosurgeon Scientist at the University of California, San Francisco. He is board certified by the American Board of Neurosurgery. Please welcome Dr. Saigal.
Thank you. Good morning. Welcome to this health and wellness seminar. I'm excited to be here and share with you some information on this topic. Today I'll be talking to you about scoliosis and spinal deformity. What is it and what can be done about it? So basically we want to tell you some of the basics of these conditions and help the audience understand when these cases are surgical, when they are, what do we do about it, and when they might not be. So I'll try to illustrate today's talk in the context of several cases of patients that I've seen and treated over many years, and we'll use that to help understand these conditions. So I'm going to start right away with a case. This is a case of a 40-year-old female patient who had a history of adolescent idiopathic scoliosis. That means she was first noticed to have scoliosis as a teenager. At that age, 15 years old in her case, she underwent a T4, meaning thoracic 4 or upper mid-back, to L1 or lumbar 1 posterior spinal fusion. This was done with the older system called the Cottrell-Dubosset system, and that she had undergone that surgery about 25 years before she met me. She initially recovered quite well and had done quite well as a teenager. She made it to adulthood, she had a family, but in the last few years before she met me, she started developing severe right low back pain. In particular, she had the feeling that she was falling over to her right side, and she also had associated right leg pain. So part of what I do when I meet patients like this is first I want to understand their history, which is what I just told you. Next, I want to examine them, and in her case, I found her to have some weakness in her right hip flexor muscle. On a 5-point scale, she was 4 points out of 5, so she had some weakness. But otherwise, she had good strength in her legs. She had some altered sensation in her right foot. So that's history, that's a physical exam, and the next thing we want to do is imaging to fully evaluate a patient like this. So we did something called a standing scoliosis x-ray. This is an x-ray that takes a picture of the entire spine. And this is her picture being shown on the screen. And first I'll draw your attention to the picture on the left. This is a picture from the front. And one thing you see in bright white, that's the old implants that were put in when she was a teenager that straighten this part of the spine. But just below that, you'll notice the spine looks curved. We measure this with something called a Cobb angle. I'm going to talk about that more as we go forward. But basically, we draw and measure the angle from the top to the bottom. In her case, this was 33 degrees in this unfused part of the spine. And that was part of what was making her bend over to her right. Then we also measure certain parameters when we're looking at her from the side. And that's all these numbers that you see here. I'm going to talk about these as well in more detail as we go forward. But basically, she was reasonably balanced if you looked at her from the side, but if you look at her from the front, she was bending over to the side. That's one set of imaging, that's an x-ray, and that's good for looking at bones and prior implants. Another type of imaging is an MRI scan, and this is better for looking at nerves. I mentioned that she had right leg pain, she had some right leg weakness. And one thing we found when we did the MRI scan is that there was compression of the nerves in this corner. This is a corner we call the lateral recess. And the nerves were kind of bunched together in this corner, and in her case that was between the level of lumbar 2 and lumbar 3. So this was an area that was well suited for decompression to help with those leg symptoms. So this patient, to fix her problem, required a fairly extensive surgery with multiple parts. First of all, we had to revise her fusion. She had previously been fused from T4 to L1. I had to extend that all the way down to her pelvis. Second, I had to decompress those levels where the nerves were bunched together or compressed. That was the L1 to 3 laminectomy. Next, to loosen up the spine, we have to do certain type of bone cuts. We call these osteotomies. So we did an advanced osteotomy, we call it type 2 at L1-2 and L2-3, and then a smaller bone cut at surrounding levels, and then we did what's called a T-lift or inner body fusion at the lowest level, 5-1. And we did all of this to correct her misalignment in her spine. And these were the post-operative x-rays. You can see a lot more implants than were there before. The old ones are still visible and present at the top. We didn't have to take those out. But we had to extend with all these new implants, screws and rods at the bottom. First thing I'll point out is that curve at the bottom is much less now. And you'll notice that she stands much straighter. And that was very helpful for her in relieving her disability. When we looked at her side parameters, we created what we call lordosis or sway in the back, and it also allowed her to stand quite straight if we look at her from the side position. Now, this is a very extensive surgery. Patients who undergo this type of surgery frequently have what we call post-op adverse events or bumps in the road, or some might say complications. So this patient ended up staying in the hospital after her surgery for 13 days. And there were a number of conditions that needed treatment during this course. So first of all, as she came out of the surgery, we noticed her platelet number was low. It was 80. We ideally would like those to be over 100, so we had to give her a transfusion. That is very common after these surgeries, particularly the big open ones. Patients often lose enough blood that they'll need a transfusion. Another issue that developed for her is her bowel slowed down. And that's frequently seen in the context of large spine surgeries where patients are taking a lot of pain medications that can slow down the bowels. So first, she noticed on post-op day 3, she hadn't had a bowel movement yet. We gave her some medicine to help with that. She started walking, she started doing a little better, but was still needing some medicines to manage her pain. And after several more days, the bowel still hadn't woken up per se after the surgery. So she needed further treatment, more of this medicine to counteract the effect of pain meds. And then after another several days, that condition finally started to improve. Ultimately, she was discharged home post-op day 13. So a very long stay, and longer than typical for these. This is just to illustrate what can happen. Now, in spite of those bumps in the road, so to speak, she was doing very well at 6 weeks. That ileus, which is, think of that as an advanced constipation that had resolved by the 6 weeks. She was not having any further bowel or bladder issues. Her right leg pain was gone. Her pain shooting down the right thigh and leg were gone, and she had full strength in the legs. So she was quite pleased with her ultimate result in spite of having some challenges in the early part of her postoperative period. So that's an example of a patient who had 2 spinal deformity surgeries in her life. One for scoliosis when she was a teenager, another one to correct a degenerative condition as she got older. So how do we know who needs any deformity surgery? What are the parameters that we look at? And when we do send a patient to surgery, what exactly do we have to correct? Thankfully, over the last couple of decades, there's been a lot of research in this area. This is an example of one paper that looked at measuring post-operative standing and balance and how do we align patients well so that they're satisfied ultimately with their recovery. This is a paper by Frank Schwab and Virginie Lafage, who have done a lot of research in this area, and this was published in 2010. So now I'll talk about some of those parameters. The first thing to think about is that we're all most comfortable when we're standing up straight. In this image, this is an illustration of something called the cone of balance or cone of economy. As you might imagine, when you're standing up straight, you're most comfortable. Your spine is balanced, your surrounding muscles don't have to work as hard because the head is naturally situated over its support further down. If we lean forward, then some other muscles have to do more work to keep us from falling over. The same is true if we lean to the side, whether it's left or right. And if we leave the cone of economy, it becomes more uncomfortable because the muscles have to do more work. So to evaluate these patients, we take a number of x-rays and we measure certain parameters on those x-rays. One of the key ones is what's called lumbar lordosis. Think of that as the sway in your low back. And we measure this by drawing a line at the top of the first lumbar level and the top of the sacrum, which is here, and then we measure the angle between those two. It's important for this angle to be sufficient to allow you to stand up straight. Another angle that we look at, or a measurement I should say, is something called the sagittal vertical axis, or SVA. Think of that as a plumb line that's dropped from the bottom of your neck all the way down, and we want to see that basically the bottom of the neck is balanced over the sacrum and the pelvis. If it's too far forward, you're going to feel like you're bending forward and you can't stand up straight. So those are parameters that we measure from the side. These are parameters we measure from the front. So when we're thinking from the side, we're thinking something that's called kyphosis, or bending forward. When we're looking at the front, this is more typical of scoliosis, or curvature in what we call the coronal plane. And to measure these, like the other parameters, we draw lines to define the top and the bottom of curved segments. And then we measure the angle between those lines. We call that a Cobb angle. So as an example, this line at the bottom is measuring the thoracolumbar or lumbar curve. In this case, it's from the top of T12 to the bottom of L4. And a patient who has a very curved area here may be imbalanced if the other curves higher up don't match that and overall balance the patient out. So that was from the front. Here's another side parameter called the spinopelvic parameters. There's a number that we're all born with called our pelvic incidence, and that has to do with how our sacrum matches into our pelvis. And we measure that with these two lines here, one going to part of the top of our hip bone called the femoral head, and the other a line defining the sacrum. And that again has to do with how the sacrum docks in the pelvis. We are born with that number. It generally doesn't change significantly, and it has to be well matched to the other number that I talked about, the lordosis, or the sway in the back, or a patient will feel imbalanced and have disability and discomfort. One thing patients can do subconsciously to try to balance that if they're mismatched is they will do something called retroverting their pelvis. Think of this as just tilting your pelvis back. And what patients do in that case, let's say they start out like this, really bent forward, they'll do an adjustment where they bend their pelvis back, and that helps them stand a little more straight. Then if they bend their pelvis even more back, then the spine can end up being straighter. So that can temporarily solve the problem, but it does so with disability because the muscles in the back of the spine have to work really hard to match that. So the goals of surgery are ultimately to get patients to certain targets where we know they will feel better. Number one, we want that sagittal vertical axis, or SVA, to be less than 5 centimeters. And that's just one parameter that they are standing up straight. We want the pelvic tilt to be less than 20 degrees. That's the amount that the patient is retroverting or tilting their pelvis. And we want what we call a spinopelvic harmony, or basically the lordosis, the sway in the low back, to match that number you're born with, which is the pelvic incidence. We ideally would like that to be less than 10 degrees. And we've studied that in patients who then report on their disability. And we found that when they meet those parameters, basically they are less disabled, they're more comfortable, and they're happier. And I'm going to show you some numbers that illustrate that. So if the SVA is less than 5 centimeters, patients report their disability as 28 points. In this scale, 100 would be the most disabled, 0 is no disability. So in other words, a lower number is better. When they reach that target, their disability is lower compared to ones who don't reach that target. Their disability is higher. Similarly, the pelvic tilt, that's how much they're tilting their pelvis. If they reach that target less than 20 degrees, their disability will be smaller compared to patients who don't. And then finally, the one that's most remarkable is when the pelvic incidence and lumbar lordosis match. When they're less than 10 degrees, patients' disability is 26, compared to patients who don't reach that, their disability is 42. Now, how do we get there? What are the surgical treatments we can offer to a patient to realign their spine when it's not there naturally or when it's degenerated over time? There are a number of different osteotomies we can do. Osteotomy is a type of bone cut, and I'm going to show you a cartoon that illustrates that. These are 6 different degrees of osteotomy. Think of number 1 as being the smallest. What's gray is what's being cut out. So this is basically a small cut in the bone that's done during a surgery. And think of that as loosening the spine, so then we can realign it and hold it in a new realigned space with screws and rods. Number 2 involves taking out an entire facet joint, this joint in the back. And number 3 is something called a pedicle subtraction osteotomy, or PSO. And this is cutting a large wedge of bone. It looks like a triangle that you cut out of the bone, and then you basically squeeze it together to recreate the lordosis, or that sway in the low back, so a patient can stand straight again. Now, as you might imagine, that type of realignment of the spine reshapes the spaces around the spinal nerves, potentially around the spinal cord, and as a result, there is some risk to the nerves nearby. Now, we've studied this to understand what number of patients, what percent of patients will experience some degree of neurological changes after they undergo that. That's important for a patient to know and to consider before they decide they're willing to undergo a surgery like this. So this was a large study that was done. It was called the Scoliosis Risk Study by some of the leading spinal deformity surgeons worldwide. And it was done because spinal deformity surgeries had become more popular. There's widely reported complication rates. There's a variability in how neurological deficits were assessed. And we didn't really have solid numbers for what percentage of patients were experiencing these. And what the study found was that about 1 in 5 patients, 22%, experience some decline in their strength in their legs after undergoing a surgery like this. So it's not a small number, 1 in 5. A patient should know that ahead of time and make sure they feel like that potential risk is worth it to them. But the other thing that the study found is that was temporary, and that decline improved with time. So that was at hospital discharge. If you then look at the same patients at 6 weeks, about 18% of them had some decline in their leg strength. And then by 6 months, that number is down to less than 11%. Now, at the same time, there's a number of patients that are not weaker, but rather stronger. And so if we look at this bottom number, about 20% of patients are experiencing more strength in the legs. So in other words, patients on average are stronger rather than weaker after undergoing a deformity surgery like this, just like the case that I mentioned. Now, the next question is, if a patient experiences a new motor deficit, in other words, a weakness in the leg, does that impact their perception of their quality of life? So here's a study that I was part of a number of years ago where we looked at that exact question. And one thing we found is that there is, of course, disability after undergoing a spinal deformity surgery, but that improves with time, and it improves in spite of changes in strength. So I'm going to start by pointing out this first set of graphs on the left. And this, again, is going after that disability number, where a higher score is worse, a change that goes up is worse. So in this case, at 6 weeks, patients who had some new weakness in the legs, they were more disabled. That kind of goes intuitively. You would expect a patient whose legs are weaker to feel more disabled. And patients who didn't experience that were about the same at 6 weeks. But then if we look further out, all the patients start to do better. 6 months, everybody's disability scores are down. And the patients who have improved motor strength are experiencing the biggest benefits. And then at 2 years, again, the improvements are even more dramatic. And even the patients who have, again, some deficits are feeling overall less disabled, and the patients who have improvements are feeling the best, as you might expect. So overall, about 1 in 5 patients experience some new motor deficit at discharge, but that number is way lower at 6 months. On average, patients were neurologically improved. Now, I talked to you about these more invasive options, which are cutting these wedges of bone into the spine. That's what's called a 3-column osteotomy. More recently, in the last decade, we've developed less invasive techniques, something called anterior column realignment. So in this type of surgery, instead of cutting a wedge out of the bone, what you can do is actually put an expandable cage or a triangular cage inside of a disc space to lengthen the spine. This can be done from the side, a side approach, and it can be done less invasively. So we've studied that. I'm going to first illustrate this with a case. So this was a 66-year-old patient, male patient, who had previously undergone a fusion from both the back and the side of his spine. He, in spite of having undergone this at another hospital, presented with disabling back pain and he couldn't stand up straight. And I'll point out some of his parameters that were off. If you look at him from the side, it looks like he's bent forward. And if we measure that plumb line, we find that the number is over 8 centimeters of how much he's pitched forward. We'd like that to be less than 5 centimeters. Similarly, his lordosis was very small. His back looks flat, and his pelvic incidence lumbar lordosis was 28 degrees apart. We'd like that to be less than 10 degrees apart. So we treated this patient with a less invasive option. We took out his old hardware. We did fusions from the side, including that anterior column realignment. We then put in some implants, minimally invasive, from the back. This patient doesn't go to the ICU. He stays only 3 days in the hospital, and you can see that he's much better aligned post-op, and he was quite pleased with his result. So here were a couple other studies that I was part of looking at this technique of anterior column realignment. And we found that, number one, we can dramatically increase the lordosis with this technique. Preoperatively in the study, patients had 18 degrees of lordosis, which is not nearly enough for almost every patient. And with undergoing the surgery, that dramatically goes up to nearly 48 degrees, and that's stable at 1 year and 2 years post-op. And on a related note, the pelvic incidence and lumbar lordosis become much more matched. We want that to be less than 10 degrees. These patients start with 40 degrees pre-op, and then it drops immediately to less than 10 degrees post-operatively, and again, that's stable at 1 and 2 years. Now, just like the other study I mentioned, we found in this study that even with this less invasive technique, there is some degree of temporary weakening in the legs as the patients are in their early part of recovery. So preoperatively, about 1 in 3 patients had some leg weakness. That goes up to a little more than 40% at hospital discharge. But then if we look further out, 1 year, 2 year, these patients are doing significantly better. At 2 years, only 11% of patients have any degree of lower extremity weakness. Another thing that's common is patients will feel some discomfort in the thigh because the side approach involves the hip flexor muscle. And patients report as much as 1 in 5 patients will have some degree of thigh discomfort or numbness early in the recovery period, but that goes down to 0 patients at 2 years in this study. So what we found overall is we're dramatically improving the lordosis. We're getting these patients matched so that they can stand up straight. They have net improvement in strength, and their thigh symptoms, which are temporary, resolve at their final follow-up. So the conclusion is that this is a less invasive technique. It can achieve some of those same parameters. It has less blood loss than some other options. Now, another thing we've learned is that we can do surgery in older patients and that we can do this safer over time. This was a large study that was published in 2017. It showed that over the last decade, the number of surgeries done in elderly patients for spinal deformity is dramatically increasing, but at the same time, the complication rates are all dropping. The blue line here is showing overall complications. That was between 25 and 30% at the start of the study, and by the end, it's around 7%. So all these complication rates are going down, and surgery can be done even in elderly patients. So finally, I'd like to end this talk with a couple cases that show the importance of treating the overall patients and going to a specialty surgeon if you do need treatment for these conditions. This first patient was someone I saw who she was 7 years old. She had a history of idiopathic scoliosis. She had disabling low back pain. On a 10-point scale, she was rating it 8 or 9 out of 10. And that had been going on for years. Her pain was worse with leaning forward. She had tried conservative measures. She tried physical therapy. She tried gabapentin. She tried Norco. She tried lumbar steroid injections. Nothing was good enough for her. Now, she had full strength, and when I got her x-rays, I noticed, yes, the spine had some curvature, but it actually was pretty small. So I did not think this patient actually needed a big deformity surgery, and I wanted to look further. So then I got an MRI scan, and this MRI scan had a very subtle finding. It had what we call modic changes. See these bright white spots on the end plates? So I offered her a very minimally invasive surgery that didn't involve correcting the spinal alignment at all. What we did in this case was just something called a basivertebral nerve ablation. Basically, we insert these tiny ports through 2 to 3 millimeter incisions, and we just ablate a nerve that's located inside of the vertebra. And this was a very effective technique for her. She didn't need any implants, and her preoperative pain of 8 to 9 goes to 4 out of 10. All of a sudden, she could live her life better and do the things she enjoyed. She was very pleased with a very minimally invasive surgery. So here's an example, again, of a patient with scoliosis that doesn't need realignment at all. It needs a different type of treatment. Now here's another example of a patient who underwent a deformity surgery that did not align him well and didn't work. He was 61, he had undergone a T6 to pelvis fusion in another hospital, but he had something called a flat back deformity. He could not stand up straight, and this is what his x-ray looked like. You can see again, he's leaning forward. That number which we want to be less than 5 centimeters, in his case is nearly 14 centimeters, and his alignment is off. Rather than being less than 10 degrees, he's 33 degrees. You can see the bottom of his spine is very flat. So what we did is we basically had to correct this surgery that was not done correctly at another institution. So basically we revised the bottom part of his spine with this operative plan. We did one of those bone cuts that I talked about, the pedicle subtraction osteotomy. And you can see in this post-operative image, now he's standing much straighter. The bottom of the spine is much more curved. His numbers are within alignment, less than 10 degrees. He can stand straight. And he also was much less disabled and was able to go back to work and enjoy his life. So in conclusion, patients improve when they are balanced and when their spinopelvic parameters are met. These are some of the numbers that I talked about that we look for. And it's important to think about all of the factors in a patient's disability, include their history, their physical exam, and all aspects of their imaging to understand what are the right things to offer for these patients. Thank you for listening. As mentioned, I'm the medical director of spinal deformity at Spinal Tumors here at Washington. I'm happy to treat any patients that have these conditions, and if you need to reach out to us, our clinic phone number is listed below. Thank you, and I'll take any questions.
Thank you. We do have some questions. What are some common symptoms of scoliosis?
Sure. So, as I mentioned in the talk, one of the things that patients will mention is that they feel like they're not standing straight. When the spine is particularly curved, it could be either off to the side, which is more typical with scoliosis, or that they feel like they're bending forward, which is more typical with kyphosis or a flat back deformity. And as I mentioned, the inability to stand up straight can be very disabling. It can affect your ability to stand and walk, it can affect how long you can walk, and it can cause a lot of pain. And so many of these patients also will have tried pain meds and other things to manage their pain, and they usually see me when those things don't work.
Thank you. And our next question, are there other health issues associated with scoliosis?
Yes. First, there are some rare genetic conditions that may be associated with spinal deformities, but that's a much smaller degree of the total body of patients. The most common setting where we see this is some degeneration that occurs with aging. Really, everyone will bend forward somewhat with aging. We call that kyphosis, and that is a natural part of aging. And there's a degree of that we can tolerate, but the problem is when it's too much, when we're bending too forward. And as part of that, sometimes when patients get significantly disabled, as I mentioned, the pain meds start to come in. And these days with the opioid epidemic, one thing we'll find is some patients are treated with opioids or muscle relaxers and end up needing those chronically because the underlying condition has not been treated. And often when we treat it properly, they can ultimately wean themselves off those meds.
Okay, thank you. And our last question is, what care will be needed at home after surgery?
Thank you for that question. The care at home is very important, and I think of patients undergoing spinal deformity surgery as being part of a team. I'm one member of the team as the treating surgeon. Obviously the patient is as well, but the family is as well, the family or any other support a patient may have. And I think it's helpful and important to have some family or other caregivers that can assist in the early postoperative period in particular. So, first of all, patients in the first week will need some help changing their surgical bandage, and a family member can be helpful for that. We generally tell them to limit bending, twisting, and particularly heavy lifting. So there are things to move around the house, even heavy grocery bags, things like that. It's helpful to have families, members available to do that. Simple light activities patients can generally do by the time they're discharged. That's things like going to the shower, taking a shower, eating meals by themselves. Those things they should be able to do. But some of the more supportive care, as I mentioned before, it is definitely helpful to have a family member for. So we like to have all those things in place before a patient undergoes these types of surgeries.
Thank you, Dr. Saigal, for this insightful presentation. This concludes our program, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.